Let's join Dr. Robert Docks for a discussion on bites, stings, and other emergency things.
On to bites, stings, and other emergency things. I still have nothing to disclose. I have my learning objectives. And I actually want to talk first a little bit about cellulitis and soft tissues infections before we go into the specific bites and stings. So when you say cellulitis, that's usually not good enough any longer. You just can't call something cellulitis, at least according to the IDSA, the Infectious Disease Society of America. They want you to give it the prefix. Is that cellulitis non-purulent or is it purulent cellulitis? And I kind of like this. I encourage my residents to do this all the time, my colleagues. Why? Because it tells me, and should tell you, we're all using the same lingo. If you're talking non-purulent cellulitis, this is good old-fashioned garden variety cellulitis of staph and strep, what we all grew up with, staph and strep. Staph meaning the MSSA, methicillin-sensitive Staph aureus, and strep pyogenes. If it's purulent cellulitis, now we're talking community-acquired MRSA. So this gives me the opportunity to just do a little deep dive in the MRSA thing, because there's a lot of confusion about MRSA. So, back in the 30s and 40s when Fleming developed penicillin, all right, penicillin could kill Staph aureus. That was good. That lasted about 1 year, and then Staph aureus started making resistance. So we got pretty smart. We made semi-synthetic penicillins, namely methicillin, and then we can kill Staph aureus again. And then it was about the early 60s when, boom, Staph aureus said, I'm going to make resistance to methicillin also. And hence we had the origins of methicillin-resistant Staph aureus. First reports were in the early 1960s. They were very low level through the 60s and 70s until the 80s came along, and we developed a lot more intensive care units, and intensive care medicine came along, and we had these sick, toxic patients in our hospitals, and boom, all these patients, or not all these patients, a lot of these patients then got superinfections with MRSA, and led to about 16,000 deaths per year in our ICU settings from MRSA. All right. Now, in the mid-90s, late 90s, we started seeing patients show up in the ER a lot with me, would have abscesses. They have these abscesses, and you do an IND, and you get the report back, MRSA. And these are usually people who were living in close confines. Some of the first reports came from a prison population in LA, then it was a wrestling team in Vermont, and then right here, the St. Louis Rams, there was a report in New England Journal that all the linemen rubbing up against each other were getting abscesses. When you cultured them, it was MRSA. But when you did a deeper dive and you looked at the genotyping, this MRSA is very different than what had been plaguing our ICUs for the last 20, 30, 40 years. What's in our ICUs is USA 100 and typically 500. 100 is the common one. Community-acquired MRSA, all these abscesses, is USA 300 and some 400. It's a completely different bug. This stuff that was in our ICUs didn't morph and jump out into the community. It's a completely new strain, okay? The stuff in the ICUs kill you. This stuff just gives you a bunch of abscesses, okay? And the reason it gives you abscesses is that it has this pantin-valentine leukocidin exotoxin, and it just causes all these abscesses. Now, when you get a report back, from some sort of IND or some sort of path report or from the micro lab, it'll just say MRSA, and you will not know what sort of genotype it is unless you send it off to a state lab, someone who's doing this, all right? So how do you know which it is? Pretty simple. Well, first of all, the origin, where is it coming from, and what does the patient have? If it's a sick ICU patient, it typically is hospital-acquired MRSA. And you'll kind of know that also when you look at the sensitivities, and they have, all those antibiotics, and then right next to them is R, resistant, vancomycin, sensitive. Whew, thank God. All right, that's hospital-acquired MRSA. Community-acquired MRSA, you look down all the antibiotics, Bactrim, sensitive, Doxy, sensitive, clindamycin, sensitive. Hey, this is great. Keflex? No, not sensitive, resistant, okay? So that's how you know the difference. And I encourage you when you start saying MRSA, and I tell my residents, tell me which MRSA you're thinking about. Is this hospital-acquired MRSA or is this community-acquired MRSA. All right. The community-acquired MRSA, which you're going to see a lot of, if you haven't seen already a lot, patients love to tell you this: I think I got a spider bite, right? They all say it, right? Right. Not only do they say, I think I got a spider bite, they say, I got a brown recluse spider bite. The poor brown recluse just gets a bad name. No, this has nothing to do with spider bites. They may think about it because typically you get this little eschar in the middle, and it's red and swollen around, and there's an abscess around it, and there might be one or two of these, and they keep coming back. Yes, I think I got a spider bite. Treatment, it's up here. The left-hand side is garden variety, non-purulent cellulitis. You can treat it with dicloxacillin. Kind of funny when I tell my residents dicloxacillin, they go, doxycycline, you mean? No. Dicloxacillin. They go, what's that? All right, yeah, no, good old-fashioned dicloxacillin works well. Cephalexin, doxycycline, and if you're doing the IND and you need to add an antibiotic, there it is, trimethoprim sulfa, doxycycline, Clinda, and linezolid are your choices. All right, covered that. Get that off the plate, the MRSA thing. Now, on to the bites. Which of the following bites has the highest risk of infection? A, cat bite to the hand. B, human bite to the face. C, dog bite to the thigh. Or D, spider bite to the arm. Okay, answer is, 3/4 of you got it. A, cat bite to the hand. Yes, so when you're dealing with bites, we'll talk about cat bites. Cat bites, if they become infected or commonly infected with an organism, Pasteurella multicida, and cat bites very frequently get infected. Why? Because cats, when they bite, they have these little sharp pointy teeth, and they're like perfect little auto-injectors to get the organism right underneath your skin. Boom. And then you can't clean it out. All right? So cats are problematic for causing infections, cat bites, I should say. If you have a patient who presents with a cat bite, prophylaxis and or treatment if you see an early infection is with amoxicillin clavulanate. Human bites, for those of you who picked human bites, you probably remember something your mother told you, that a human's mouth is dirtier than a dog's, right? My mother always used to say that. Did your mother used to say that? Yeah, okay, yeah. So just understand, human bites, dog bites, cats, we all have a variety of organisms in their mouth, all right? But the case of the human bite, yeah, you can get infections from human bites, but in the stem, in the question, there was two things that suggested why it should be cat bite. A, its mechanism, okay? B, it's the hand. The hand is a place that you often will get a lot of infections. And in the case of the human bite, it was a human bite to the face. All right? So bites to the face, scalp rarely get infected. Why? Because they have such a good blood supply. They have such a good blood supply. Think about it for a moment. How many times have you bit your lip? It never gets infected, right? Because you have such a good blood supply. Bad organisms there, but a good blood supply. All right? So, human bites can happen. Again, watch out for what I like to call the closed fist injury. That's the Friday night boxer special. They like to go after someone else's mouth. Boom. So, that's a human bite to the closed fist. The organisms there are all the human organisms in your mouth, the Peptostreptococci and all those. Again, if these show up, you irrigate, clean it out, prophylaxis with amoxicillin clavulanate. And then the dog bite, not as commonly get infected. Why? Because dogs, what they do is they bite and tear. Now you have a big open wound. You can clean that out really, really, really well. So you don't always have to prophylax a dog bite. If you want to, you go with amoxicillin clavulanate, but you don't always have to. There's a couple exceptions to that bite and tear. One is those, little nipper dogs. I don't know, those little dogs. The other is police dogs. Police dogs are taught to bite and hold, and you don't get away. You'll have a crush injury, but they won't tear, because that's what police dogs are trained to do. All right, here's the long list of infections. I've just gone over cat bite, dog bite, human bites. Other things you have to worry about is anthrax infections from animal hides and carcasses, freshwater injuries that's up there. Watch out for the saltwater cellulitis that shows up. That's a non-purulent cellulitis that's often Vibrio fulnicus. I can't say it. Fulnicus. This is a bad infection, the saltwater cellulitis or infection. That has to be covered, as you see up there, with the third-generation cephalosporin plus additional coverage. So two antibiotics. Fish tank exposures up there and hot tub exposures up there also. So covered those. Cat scratch real quick. Finishing off with these animal diseases here. Common, what happens with cat scratch is you get a regional lymphadenopathy. Cat scratches you. You get some regional lymphadenopathy that most commonly gets scratched in your hands and arms, so you get epitrochlear and axillary lymphadenopathy. Please don't IND these. They don't need an IND. This is a self-limiting disease that's due to an organism that's a gram-negative rod, a small one called Bartonella. That's the name of it. If you took the boards 10 years ago, it's likely that the answer is we don't know the organism. It's only in the last 10 years or so that this organism has been identified, but that's the organism. Again, self-limiting disease goes away after 1 to 2 months. I will throw this out. There's one very small study, like 30 patients, that said, look, if we use azithromycin, resolution happened a little quicker. So this led to the authors of UpToDate to say the following: although some experts would suggest not treating typical cat scratch in immunocompetent patients with mild to moderate disease, we suggest a 5-day course of azithromycin. It's a very low-grade recommendation. The textbooks will tell you still it's self-limiting, don't treat. These experts say treat. I don't have the right answer for you, all right? I would guess if they give you the question, I'd probably go with the textbook answer. It's self-limiting, you don't have to treat, although whoever's putting the questions together may go with the experts, these experts from UpToDate. All right, next case. 24-year-old male presents with a 3-day history of a rash that is increasing in size. It's not painful or tender. It's flat, oval, large, 14 centimeters by 7 centimeters in size, has central clearing, and has no fluctuance. I'll show you a picture in a second. He has no fevers, chills, or systemic symptoms. He has no new medications. He doesn't recall any insect bites, and he recently vacationed on Martha's Vineyard. All right, this is a true case. This young man came into our emergency department. That was his rash, right over across the iliac crest. So in this case, you would A, prescribe azithromycin 500 milligrams for 5 days. B, prescribe doxycycline 100 milligrams BID for 10 days. C, obtain a Lyme titer and if positive, treat with ceftriaxone. Or D, obtain a Lyme titer if positive, confirm that with a Western blot study, and then if positive, treat with ceftriaxone. Okay, great. Almost all of you got it. B. You know that that's the rash of erythema migrans associated with Lyme disease, and so you do B, prescribe doxycycline 100 milligrams twice a day for 10 days. So a quick ditty on Lyme disease. It's due to the spirochete Borrelia burgdorferi. That spirochete lives in the gut of the deer tick, and it's typically the nymph stage, that's the second one in from the left there, that gets on you, has its blood meal for about 36 hours or so, and at the end of the blood meal, regurgitates its stomach contents, which has the Borrelia burgdorferi spirochete, back into you. That's how you get Lyme disease. You're well aware Lyme disease plagues the Northeast and the Middle Atlantic states and the Upper Midwest. The early manifestations are erythema migrans. 50, 60, 70% of patients will have the rash. If they show you a picture, they will often show you the classic bullseye. I wish patients were, I live in a hotbed of Lyme disease. We see a lot. They sometimes look like this. They often come in all shapes of variety, but the thing is, it's often a very large rash, large red rash that is not warm, it's not tender, it's not cellulitic. So if they give you pictures, it will be the classic bullseye. All right, so that's early Lyme disease. The other manifestation of early Lyme disease is neurologic presentations. We often see a seventh nerve cranial palsy. So it's not Bell's, because Bell's is idiopathic. Here, there's a reason for this. So this is seventh nerve cranial palsy. Actually, one of my most favorite cases I had in the ER, this has to be about 12 years ago, was a gentleman who came in who worked outside frequently, often get a lot of ticks on him. Came in one night and said, I can't move my face. You can't move your face. I can't move my face. Like, you can't move your face. He had Talk about bad luck. Bilateral seventh nerve cranial palsy is from Lyme. That's bad luck. Not only do you get it on one side, he got it both sides. Yeah. So yes, be aware. I only say be aware because he saw a provider the day before who said, "Oh, you're just anxious. Here's some Xanax." Yeah, I'd be anxious if I can't move my face. Right. All right. You can get the cardiac disease. So if you have a young person who comes on in and all of a sudden they got an AV block of some sort, think that ain't right. In our neck of the woods, we think Lyme disease. The late manifestations of the Lyme arthritis. This is a child we had in the ER. You can see what happens. It's the large joints that get involved. We often see these knees that get really, really swollen. This child had both knees very, very, very swollen. It's not, oh, I woke up this morning and I'm stiff and achy. That's not Lyme disease, okay? Big swollen joints. You can get late neurologic findings of encephalopathy, and then even after you treat some patients, adult patients, for some reason it doesn't happen in children, but adult patients, some will have the post-Lyme disease syndrome, which according to the IDSA is, quote, unexplained chronic subjective symptoms following treatment. I'll leave it at that. So, in stage 1, you have the rash, you see it, you treat it. So who do you do a test on? So the CDC is very clear on this, that you do a test in patients who have unexplained symptoms. All right, so you're not sure. You're sort of in that test zone, 50-50. Maybe it's Lyme, I don't know, I'm not sure. This sort of weird neurologic thing, maybe it's Lyme. So in those situations, you do your Lyme titer, and if it's positive or equivocal, if it's positive, you don't call it Lyme yet, you do your confirmatory test, which is the Western blot. So it's a two-step testing system for Lyme if in those patients with unexplained symptoms. All right, if you're treating just stage 1, it is 10 days of doxycycline. You don't need 2 weeks, 3 weeks, 4 weeks. You don't have to pull out Rocephin, the big guns. This is a spirochete, okay? Just like syphilis, right? How do you kill syphilis? 1 shot of penicillin, it just rolls over and dies. This organism, you give it some doxycycline, it just rolls over and dies, okay? It's a spirochete. It'll die, all right? If you have the complications of the disease, then it is longer regimens. But 10 days of doxycycline is fine. And if you do treat the patients, please tell them, I'm giving you the doxycycline. Tomorrow, you're going to feel terrible. It's not an allergic reaction. That's the Jarisch-Herxheimer reaction. Just like syphilis. You remember syphilis, right? You give penicillin, they get the aches. They feel a little achy, feverish, headachy. It's because the spirochete is dying and it's lysing all its contents into you and you feel like crud. All right? That's what happens in syphilis. That's what happens in Lyme disease. All right? It's not allergic. Mr. and Mrs. Jones, just take some Tylenol. It'll be okay. It's not an allergy to the doxycycline. Okay? All right. Should you do a Lyme disease prophylaxis? In other words, this person comes on in with a tick on them, or they took it off and they tell you, I had this tick on you. All right, so what does the IDSA said? They say routine antibiotic prophylaxis is not recommended, although you can offer 2 tablets of doxycycline if all these conditions are met. That is, the tick can be identified as a deer tick. Like you're an entomologist, right? Okay. So you know it's a deer tick, and it's been on you for at least 36 hours, and you can start this prophylaxis within 72 hours of this occurring, and your local rate of infection is high, like in my neck of the woods, and you can give doxycycline. All right, so you can do that. All right, I know a number of people who do that. It's pretty common in my neck of the woods, although we are not entomologists, but we have enough deer ticks up by us that is a pretty common practice up in my neck of the woods. All right, the other 2 deer tick conditions to know about is 1, anaplasmosis. I saw 2 or 3 cases of anaplasmosis this past summer in our place. This is the person who comes on in the middle of the summer with the flu-like illness. They look like, you think, influenza? No. You have this flu-like illness, you're feverish, and then when you get their labs, you say, holy macaroni, you've got thrombocytopenia, your white count is down, and your LFTs are up. Bing, 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 these are things we start looking for at our place, and then we test for anaplasmosis. That's anaplasmosis. Babesiosis, pretty similar, but babesiosis is actually an intracellular parasite. So just like malaria, it gives you malaria-like symptoms. You get these waxing and waning fevers, weakness, and then when you start doing the lab work, you see this hemolytic anemia, thrombocytopenia, and elevated LFTs. So that's babesiosis. The only other tick-related disease I think you need to know for the boards is Rocky Mountain spotted fever. That is not a deer tick. That is a dog tick or the wood tick. Most common more in the southeast United States and also Colorado, Rocky Mountain states, but southeast is a little more common. There you start with a flu-like illness, and then when you get the rash and multi-system involvement, that's Rocky Mountain spotted fever. All right, allergic reactions. Speaking of allergic reactions. 64-year-old male presents in the emergency department with diffuse pruritus and erythema along with facial and oral swelling. This occurred 15 minutes after eating peanuts. His blood pressure is 65/35. That's bad. And he's tacky at 120. This is what he looks like. He's got these big red swollen hands, the rash up the arms, he's got a swollen face and lips. And so the first medication this patient should receive is A, epinephrine, B, diphenhydramine, C, methylprednisolone, or D, ranitidine. Okay, good. Almost everybody. It's epi you're given this situation. So, yeah, a lot of patients with allergic reactions will get hives, urticaria or hives. You can treat that simply with H1 and H2 blockers. You can get, kicking up a notch, angioedema, which now involves the more deeper dermal layers, and you can get swelling in the face, neck, and tongue. And then you get anaphylaxis, which can occur anywhere from a couple of seconds to hours after eating the thing you're allergic to. And there you get a whole host of symptoms, the skin, the respiratory, the hypotension, some GI distress. Just for your own knowledge, you don't think they'll ask this, but just to recognize there's a difference between anaphylaxis and what we used to call anaphylactoid reactions, or what is now known as non-IgE mediated non-immunologic reactions. So anaphylaxis typically is IgE mediated. That is, the first time you had a peanut, you had no problem, or penicillin, you had no problem. But then your body said, I really kind of like this, so I'm going to make some IgE. And the next time I see that IgE is going to recognize that, and it's going to attach to those mast cells and basophils and cause all this degranulation, and all heck is going to break loose. That's anaphylaxis, or anaphylactic reaction. Anaphylactoid or non-IgE mediated responses have nothing to do with IgE. That is when you give someone, for those of you who work as hospitalists, I bet you get calls at night, someone gets some morphine and they start getting itchy, okay? Because morphine has a direct effect right on the mast cells and basophils, okay? Same thing with radiocontrast media. So you don't have to see this once before, it can happen the very first time. You treat them exactly the same. All right, treatment is exactly the same because you've got all this histamine response going all over the place, okay? So, front line, epi, that's what you use. It's up there. If you're working in your hospital, you use the top one, the 1 to 1,000. That's what's in an EpiPen. Typically, you give 0.3 mils. That's the adult dose. The child dose is half of that. You only go to the IV stuff only, and you do it as an IV drip preferably, when it's life-threatening, okay? Never give the thing on top IV. Don't do it, okay? All right. So a common question that comes up on the in-service and the boards is the following. If the EpiPen is used, they call you up, I just used my EpiPen. Your response to them is what? Go to the ER. Correct. Why? It's this concern about this second wave that can occur. All right, in other words, a late reaction. So it's really interesting. I see these patients come in, dutifully they come on in, and they come in and they feel better now because they took their EpiPen. So they're there, and I get the history, and I say, how you doing now? They go, I'm fine now. I took my EpiPen. I say, that's good. They say, well, that's good. And I say, well, that's good. They go, well, how long am I going to be here? And I'm like, I don't know. No answer. I don't know how long you should sit here. There's no right answer. So I just I say, you get to sit here as long as you want to sit here. Because this late or biphasic reaction, by the way, is exceedingly, exceedingly rare. The data's up there. It's only 5 out of 2,000 plus cases. So it like never happens. So I'm like, hi, you want to hang around a little bit? Fine, hang. I think that's fine, hang. You're paying for it, you know. All right, but hang, and I'll just watch you. And then when you feel like going, you go. And if it comes back, you come back. That's it. All right? Nothing else to do. They go, I came all the way here for you to do nothing? I'm like, sorry. Yep, that's the case. All right, we just watch them. All right, so you give epi, epi, epi. You can give an H1 and H2 blockers, and you can give steroids, although there's no data to ever support using steroids in this, by the way. It's just sort of extrapolated from the asthma literature. All right, this is not an allergic reaction. You've probably met this patient before. This is the person who wakes up the one morning and they either call you, come into the office, or you work in the ER or urgent care, and they say, I have this history of hypertension, and then boom, I woke up this morning and look, my tongue was all swollen. All right, you've all seen this patient now? Okay, yeah. So this is what? This is ACE-induced angioedema. All right, ACE-induced angioedema is not an allergic reaction. It has nothing to do with IgE. As was noted by Dr. Levine in the last lecture, it's thought that because of the inhibition that you get accumulation of bradykinin over time, and you just get this weird idiopathic reaction that is more common in African Americans, more common in women, and it can happen day 2 of using your ACE, or it can happen year 12 of using your ACE. It's really weird. And if you've seen these, I've probably seen 20 or 25 of these in my career at this point in time, because a lot of them come in the ER, because they wake up and say, "Man, my tongue is all swollen." Sometimes it's the whole tongue. Sometimes, as you can see here, these are pictures of patients I had. Sometimes it's just the lips and the tongue is fine. Sometimes it's just half the lip. That's weird. I've seen half a tongue. That's really weird, okay? So what is the treatment? There is none. It's supportive, all right? Because this has nothing to do with histamine. Now, I will tell you, the picture of the lady on the left where she's about ready to lose her airway, all right, I know, and my colleagues all know, that giving a bunch of meds do nothing but, oh my gosh, we start giving the diphenhydramine, H1 blocker, H2 blocker, steroids, we start throwing the kitchen sink at you, just in hopes that you don't lose your airway. It does, loss of airway does happen on occasion, and if you try to intubate those patients, they're extraordinarily difficult. So some of us will throw the kitchen sink at there knowing they don't work at all. So treatment supportive. All right, bee stings, more bites and sting stuff. Bee stings, local reactions are common. I can't tell you how often patients come in saying, I have an allergic reaction to this bee sting. Look, I get this area that's red, swollen, and itchy. It's about the size of a $50. I'm like, that's normal. That's normal. Why? Because the venom of bees have a number of vasoactive peptides, including histamine. So if you got a little shot of histamine under your skin, what do you think will happen? You get a little itchy and a little red. That's okay. That's normal. Little H1 blocker, no problem. Toxic reaction can happen when you get a lot of bee stings all at one time. You can get delayed reactions, and yes, you can get anaphylaxis. There is a condition known as pseudo-fish allergy called scombroid poisoning. I've seen one case of this I know of, and I probably missed a bunch, but this is an interesting reaction. It's called scombroid poisoning after the group of fish known as scombroides, which is the dark meaty fish, the mackerel and the tuna, but it can happen to any fish that is poorly preserved. What will happen is if the fish is poorly preserved, fish in their muscle, they have histidine, all right? And if you have bacterial degradation of that histidine, it is degraded to histamine. Now imagine eating this fish meal that's full of histamine, right? You will get itchy and red, right? You just ate a histamine meal, all right? So you treat that, again, with just H1 and H2 blockers. That's scombroid poisoning. It's self-limiting. You'll do okay. You're not allergic to the fish. All right, ciguatera poisoning. This is an odd one also. It has to do with the reef fish, like barracuda, grouper, that are along the reefs, and they will ingest these dinoflagellate, which contain a neurotoxin. So it gets into the fish, then it gets into you. And you get these weird neurologic symptoms. I've not seen a case of this, and usually when I ask the audience, someone's seen like one case. Has anybody seen a case of ciguatera poisoning? Okay, so it's classically described, I'll see what your experience like is with it, that the weird neurologic things are like when you touch something cold, it'll feel hot. If you touch something hot, it'll feel cold. You get these weird neurologic things. What was your experience? I'm curious, because I hear all different stuff. Oh, you only saw it a month later in follow-up. Did he tell you what his symptoms were, or did he?
At that point, they were just having kind of
Headachy, just weird neurologic stuff. Okay, yeah. So just be aware of ciguatera poisoning. All right, cold-related injuries. Just know the difference between frostnip and frostbite. Frostbite, you get tissue loss. The cells die. If you come in with frostbite, we will do rapid rewarming in circulating water of 104 to 108 degrees. Heat-related illness, this was covered a little bit this morning by Dr. Geary already, so I'm not going to say much about this. The classic heat stroke has CNS dysfunction, although you can have it in the younger individuals like the military recruits or the athletes, who it's all due to exertion, and they will sweat. Okay, the classic elderly person who's taken an anticholinergic will not sweat. The treatment for either type of heat stroke is evaporative cooling or immersion cooling. You can give all the acetaminophen in the world, that doesn't work. You have to cool these patients topically. All right, last, toxicology. And I'm going to blow through toxicology very quickly, and I'll just ask you to study the toxicology. This is a case, we're not going to do it because I'm running out of time, but this is a case of an acetaminophen poisoning. So just look up acetaminophen poisoning. They like to throw that one in on you. I'm going to move on to save some time. When it comes to gastric decontamination, no more Ipecac, no more gastric emptying. Charcoal is your best friend. Acetaminophen toxicity is up here. These are the other toxicologic emergencies to know about. On the left-hand side, the ingestions. On the right-hand side is the antidote. Just draw the line between them. And then recognize the anticholinergic syndrome, recognize the serotonin syndrome, what they present like, the difference between the two, and then you treat the serotonin syndrome with cyproheptadine. And I'm going to say thank you very much.